And welcome to today's webinar. I will be talking about the impact of the removal of hepatitis C, also known as HCV, treatment restrictions on the progression through the HCV care continuum. Thank you so much to Sheena and Kyle for having me. Here is the group of people that I work with on a day-to-day. I work at Philadelphia Fight within the viral hepatitis program and specifically with the C A Difference program, which is working towards Hep C elimination at Philadelphia Fight, in Philadelphia, and country and worldwide. And these are all my amazing colleagues. What is hepatitis? I'm going to give you a little bit of a Hep C 101 for those of you it's not as familiar with. Hepatitis in general is just inflammation of the liver. It may progress to liver fibrosis, cirrhosis, or liver cancer. A little bit of scarring is called fibrosis, and a lot of scarring is called cirrhosis. And having cirrhosis can put someone at high risk of liver cancer. Hepatitis viruses are the most common cause of hepatitis, but hepatitis can also be caused by other infections, toxic substances such as alcohol and certain medications, and other autoimmune diseases. There are some symptoms of hepatitis. There are many, and sometimes someone with hepatitis might not experience any of these symptoms. They are jaundice, pain in belly, loss of appetite, nausea, fever, diarrhea, fatigue. And like I said, people can be living with hepatitis for many, many years and not experience any of these symptoms, or not realize that the symptoms they're experiencing are from hepatitis and think that they're related to other things going on. Hepatitis C, specifically, there's three types of hepatitis, hepatitis A, B, and today we're going to be talking about hepatitis C, is a highly contagious viral liver infection. It spreads via contact with the blood of someone who has the hepatitis C virus. There's no hepatitis C vaccine, but there is a cure for it. And that cure is 1 to 3 pills 1 time a day. And the treatment duration is as short as 8 weeks or 12 weeks. And there are almost no side effects. In 2013, curative treatments known as direct-acting antiviral agents, also known as DAAs, were introduced to combat hepatitis C, and they offer cure rates near 100% with minimal side effects. That means that close to 100% of people, between 95 and 100%, cure from a full course of treatment. It is covered by most insurance companies in Pennsylvania, but that's what we're here to talk about. And treatment allows people to avoid liver failure and cancer-causing cirrhosis, liver transplants, and other costly health complications. So this cure and this cure being available to people is really important for individual health and for our public health. So the majority of the people with Hep C these days contracted it from injection drug use. It's about 60%, but I believe this has grown since this study was conducted. The second common transmission category is sexual, and the other lower type of transmission category is transfusion, prior to 1992 when they implemented universal precautions in hospital settings. We have a natural history of Hep C infections. So someone who is infected with Hep C can either have acute Hep C or chronic Hep C. So someone with acute Hep C, about 15% to 25% of them will have a spontaneous resolution, which means that they can clear the virus on their own. But 75 to 85% of the people who contract acute Hep C, it does not clear from their body, and it develops into chronic hepatitis C, which means it will not go away without the use of direct antiviral medications that we were talking about before. And that chronic hepatitis C might lead to hepatic inflammation, that means of the liver, hepatic fibrosis, the scarring we've discussed, and potential cirrhosis. And it leads from fibrosis to cirrhosis depending on the person. Someone can have hepatitis C for 20 years or more without developing cirrhosis. But some people who might have, I think I can use a pointer here, alcohol, HIV, and hepatitis B may accelerate this fibrosis and lead to cirrhosis within a shorter period of time than someone who do not engage, do not drink, or do not have HIV, or do not have hepatitis C. The next stage from cirrhosis is hepatocellular carcinoma, which is a type of liver cancer, and hepatic decompensation. There are extrahepatic manifestations associated with Hep C, which means that the entire body is affected, not just the liver, even though hepatitis is specifically a liver virus. So someone with hepatitis C can have blood problems, skin problems, kidney problems, neuropsychiatric, eye problems, vascular problems, neuromuscular problems, and it can have autoimmune phenomenon as well. So we have estimated the amount of people who have hepatitis C, and the estimations are between 170 million to 200 million worldwide. And now this map represents, the colors represent genotype, which are just genetic strains of the virus. They don't, and they really only, the measurement of the genotype really just determines which type of Hep C medication is prescribed. My boss has always described these colors as flavors of ice cream. So they don't, they are just descriptive and will determine what kind of medication is used. But these days we have what are called pangenotypic medications, which means that they have medications that will treat all genotypes, as opposed to a few years ago, we had medications that were only for genotype 1 or genotype 4. So now with the development of medications, we're able to treat more people and have people have greater access to the treatment. Zooming in on the United States, we have the statistic that that hepatitis C is the most common bloodborne infection in the United States. And I know our team likes to get this word out because I think that a lot of people in the mainstream don't realize how common and how deadly hepatitis C is. So that's why we want to make sure that everyone understands this. We have about 3.2 million to 5.2 million people chronically infected, and these these stats come from NHANES, which is the National Health and Nutrition Examination Survey. And this is a study that doesn't include non-institutionalized US citizens or undocumented folks or people experiencing homelessness. And so we believe that a large majority of this statistic is uncounted. So we think that these numbers are even higher because they're not being counted. And over 50% of individuals chronically infected with Hep C are unaware of their infection, which is why we think that testing is a really important part of this program and the need to eliminate hepatitis C. Because if someone doesn't know they have it, there's no way that they can get it cured. The CDC now recommends that all individuals over 18 should be tested at least once for Hep C. This is relatively new. Previously, they just recommended that all people who might have had a risk factor like injection drug use or a sexual encounter with someone who might have had Hep C or were in the baby boomer category, because this was previously the most common category of people with Hep C. So this is major because now we are including everyone in this test at all health centers as well. And so in addition to that, all individuals outside of this cohort with the Hep C risk factors that I just mentioned should be screened more frequently, more than at least once. The AASLD, which is the American Association for the Study of Liver Disease, and the IDSA, which is the Infectious Disease Society of America, recommend that treatment is recommended for all patients with chronic hepatitis C infection, except those with short life expectancies that cannot be remediated by treating Hep C, by transplantation, or by other directed therapy. Patients with short life expectancies owing to liver disease should be managed in consultation with an expert. So not only, I'll go back this slide, that is CDC recommending that hepatitis C be tested on every single patient over 18, but the AASLD, IDSA groups are recommending that everyone with Hep C is treated. And now this is relatively new as well. which we'll get into in a moment too. There's a pre-treatment evaluation that needs to happen before someone is treated with Hep C. Factors that may need to be addressed prior to treatment initiation might be pregnancy screen or screening for renal disease. There needs to be an HIV assessment if co-infected with HIV and hepatitis C. And there needs to be a liver disease assessment, which encompasses many labs that determine what kind of medication is used for the treatment, including CBC, INR, and CMP. And if there's hepatitis B, a quantitative Hep C RNA, which is to show the level of Hep C in the body, the genotype that I showed you on the worldwide map before, treatment history, like if someone had been treated previously, we are very willing and open and wanting to retreat someone even if they were treated and then reinfected, and disease staging, which I'll get into in a moment. So this is the disease staging. Liver disease progression is shown here in these images. You can see over here, this very pink and smooth image is a healthy liver, and that's classified as F1. This is fibrosis. Fibrosis to cirrhosis over here. And so the healthy liver is classified as F1 to it starts at F0 to F1, and then it progresses to F2, F3, and F4 is considered a cirrhotic liver. And then moving from cirrhotic liver, someone may be at risk of developing liver cancer and may be in need of a transplant. So there are some health measures in patients with Hep C that are recommended to people who are living with Hep C in order to decrease the progression from F0 to F to the higher F numbers. People living with Hep C are requested or recommended to not smoke or at least reduce their smoking, to consume minimal to no alcohol, to not share toothbrushes or razors, or other things that might transfer even a minimal amount of blood between people, to lose weight if overweight, to talk to your doctor or other medical provider about all medications or herbal products, to be proactive about getting treated, and to not get lost to follow up, because it's really important to get treated as soon as possible and to follow up for labs to make sure that the treatment worked as was planned. So the staging of the Hep C liver fibrosis is really important. It's important to determine how long treatment is or what kind of treatment. And there are two ways that we determine liver fibrosis. We do it at Philadelphia Fight with FibroScan, which is a specialized ultrasound machine for the liver, or a FibroSure, which is a blood test. And both will determine an F score, or it's another word is called a Medivir score, and that will show us how sick a liver is. Unlike previous treatments, or unlike in previous years, we do not do liver biopsies. They're only performed by hepatologists in the event that a patient must enter hepatology subspecialty care or do liver transplant. But we only use these very non-invasive practices to determine liver fibrosis. Now getting to the topic at hand, we have many treatment restrictions in the United States. Unfortunately, despite the important individual and public health potential of the cure of hepatitis C that I mentioned before, many state-based Medicaid programs have limited access to hepatitis C treatments, and this is due to cost concerns. These medications used to be incredibly expensive and got a bad rap for being incredibly expensive, but the truth is that they're cure medications and cost a lot less than treating someone for cirrhosis or liver cancer. And so we have determined that over the years, that these restrictive criteria are unfair and are actually causing a lot more harm than care for our patients living with Hep C. And there are three specific restrictions that I want to highlight here. The first one is sobriety requirement, and that is basically barring patients with a history of substance or alcohol abuse or use, So a lot of payers require that there's a documented history of abstinence from alcohol and drugs for up to 6 months prior to treatment. That does vary between state. Then there are the disease severity restrictions, and this requires that patients reach a certain stage of fibrosis, meaning that a lot of patients in some states need to be sick enough to receive treatment. And so a lot of patients are told that they need to have, F3 or F4, as opposed to just getting it cured when they're F0 or F1, so that it doesn't progress to F3 or F4. And then we have the prescriber requirement, which only allows certain specialists who are not readily available in certain areas of the country, especially in more rural areas, to prescribe a cure, as opposed to it being more accessible in primary care settings that we've developed at Philly Fight and throughout Pennsylvania. So here is a map of disease severity. I'm going to show you a map for each of the 3 restrictions, the first being disease severity. And as you can see, here's our key, and we have the lighter colors going all the way to white are show you states that have no restrictions in disease severity. And then as it gets darker, it shows you that a patient needs to have chronic Hep C regardless of disease staging, F1, F2, F3, and the states with the darker colors require a disease severity of F4. Comparing 2014 to 2018, we see that the states have certainly lightened up, and we see that especially Pennsylvania here, which is what we're talking about today as well, has currently no restrictions in disease severity. And the restriction for chronic Hep C is important too, because it shows that we aren't waiting for someone to clear the virus on their own. We're actually going to treat people regardless of if it's an acute infection or a chronic infection, because we know that even when someone has an acute infection and they're waiting for their body to clear the virus, they still might be contagious. So I'm going to say this again later in the webinar, but we are really taking a treatment as prevention an approach to this public health problem. We also see the states throughout our country lightening up about the sobriety, although I think not as much as our disease severity. And I think that has a lot to do with stigma related to drug use. But we do have some states that still have had no restrictions, as you can see here in the white. And I'll read you these. I'm sorry if it's kind of small on your end, but in white we have no restrictions. In pink we have screening and counseling, and that can be done by the medical provider. It doesn't need to be a referral to a specific drug treatment program. The lighter pink here shows that states require a patient to abstain from drugs for 1 month, and then abstain for 3 months, abstain for 6 months, and the most restrictive require that patients abstain for 12 months. And this is a really difficult thing to look at, because what we know about Hep C is that it causes liver damage, as does alcohol use. And so someone who is living with hepatitis C, if they use alcohol at the same time as having hepatitis C, this is like throwing fuel on a fire and can increase the inflammation of the liver exponentially. So it's really important to use harm reduction principles in this and help people, if they get rid of their hepatitis C through a cure, then we are completely reducing, not completely, but we are reducing the inflammation of someone's liver, probably exponentially as well, even if they're continuing to use alcohol. So this is quite discriminatory. Our next restriction is prescriber specialization. And I just updated this here because I think as of now, we have no restrictions in Pennsylvania. Sorry, I didn't tilt that to fit Pennsylvania perfectly, but that is Pennsylvania with no restrictions. But we see that it has lightened up to increase access to medication regardless of access to a specialty provider. And I think this is really important because, like I said, and for the majority of the country who live in urban areas, or excuse me, rural areas, they might not have as much access to a specialty provider that are more concentrated in urban areas and might need to travel very far to find a specialty provider. And so really expanding access within primary care is what is going to help us move towards elimination of hepatitis C. This is another way to show that we have seen changes to Pennsylvania Medicaid direct acting antivirals. In 2014, we did have the restriction of having F3, F4 be the requirement for someone to have treatment. There was no exception for HIV patients, so people who were living with HIV and hepatitis C did not get any exception for getting their hepatitis C treated, even though we know that HIV speeds up the fibrosis towards cirrhosis quite a bit. There was a sobriety requirement of no drugs or alcohol for 6 months, and they did need to see a specialist physician in 2014. We've progressed quite a bit to 2018, whereas right now we have no severity requirement as of January 1st, 2018, which means that anyone can get hepatitis C even if they have zero scarring of the liver, which makes sense because medically we would like people to stay at having zero scarring of the liver. There's currently no sobriety requirement in Pennsylvania, and there is no provider requirement, which is how we were able to expand our treatment within our primary care settings and assist other primary care settings to provide treatment as well. When insurance will not cover drugs, what are the options for patients? Well, they can wait for new drugs to be approved, which takes a really long time. Then there's no guarantee that even when the drugs will be approved, they'll be covered by state-based Medicaid or other insurance companies, or that the patient will qualify. They can wait until patient qualifies, which means that a patient might need to stay sober for a period of time that they're not able to. And they might have to wait until their F score or fibrosis level increases and makes them even sicker. They can take legal action, which is what we've done across the country and within Pennsylvania to advocate for the removal of restrictions, or they can apply to patient-assisted programs to obtain free drug outside of insurance companies. But these have been very difficult. I've experienced this firsthand, and there's only one company that does this currently, at least in Pennsylvania. We need to acquire patients' financial information in order to have them qualify, which creates a lot of barriers as well. And we need proof that patient does not qualify for insurance, which means that we need to apply them to insurance and then have a denial letter. And this is really challenging for patients individually to navigate. Not every clinic has the infrastructure to be doing this for every single patient. It's really, really difficult. So that's why we need to really advocate for the removal of restrictions. Here's an example of a treatment cascade for people with chronic hepatitis C. We see that 100% of this are chronic hepatitis C infected. About 50% are diagnosed and aware. This is a major gap that we're working on, and that is a whole nother study as well about testing and linking people. Then a smaller subset of those people have access to outpatient care. A smaller subset of the people have a confirmed HCV RNA, which means that they have a confirmed chronic infection, or a confirmed viral load, excuse me. Then a smaller subset of those people are able to get liver staging. And then even smaller, those people are able to get their Hep C treated. And then even smaller, those people are able to achieve SVR, which means it's just another word for cure. SVR stands for sustained virologic response. And so what we're focusing on within this cascade, I'm going to show you as I get through the study part of this presentation. And this is the arrow that we're focusing on. it's demonstrating that where treatment restrictions lie are between confirming Hep C RNA and liver staging and actually accessing treatment. But what we'll demonstrate also is that access to treatment really impacts this part. Once someone is aware of their virus, they may not even access treatment if they know that they may not qualify because they may not be able to abstain from drug or alcohol use, or they might think that they need to be sicker. So it's not really impacting here to the treatment prescription and the approval from the insurance company. It's really impacting the entire cascade. So onto a little bit of background about the study. As I mentioned, in 2018, January 1st, 2018, Pennsylvania Medicaid removed disease severity criteria from prior authorization criteria for hepatitis C treatment, which means that Pennsylvania Medicaid now does not require someone to be sick enough in order to receive treatment. We wanted to assess the impact of this change, so we compared the rates of progression through the HCV care cascade that I showed you in the last slide during the year prior to and after January 1st, 2018 in patients treated in a federally qualified health center, also known as FQHC, you might hear me say, in Philadelphia, PA. We also compared the progression through the cascade and those identified through a community-based testing model or program to those tested in the FQHC. And I'll go through what those groups look like here. So we had two groups. Excuse me, So in order to look at the impact of the removal of restrictions, we are comparing the full year before the removal and the 4 year after the removal. So that's January 1st, 2017 to December 31st, 2017, compared with January 1st, 2018 through December 31st, 2018. And we had two groups. We were also interested in comparing two specific groups within these years. Group 1 included adults diagnosed with chronic hepatitis C who were initially tested in the community, such as at one of our partnering substance use treatment program sites, and then navigated to Fight's clinic. Group 2 included adults diagnosed with chronic hepatitis C who were initially tested in our clinic space and then treated within the same clinic space. So group 1 and group 2 split between 2 years gives us essentially 4 groups actually. And so that's how we made our comparisons. We evaluated group 1 and group 2 for progression through the HCV care continuum during these 2 time periods that I just mentioned before. We used an unpaired t-test to compare mean time to each milestone, and we used chi-square testing to compare rates of insurance approval and treatment initiation. For both of these tests, we used a significance level of 0.05. One second. And here is a graph that shows our demographics, but our total numbers are in 2017, we had 556 adults with chronic hepatitis C. 65% of them were in group 1, and to remind you, that meant people tested in the community and navigated to the clinic. 35% were tested in the clinic and navigated to the clinic, to the same clinic in group 2. And in 2018, we had 496 adults with chronic hep C, 74 of them in group 1, and 74% of them in group 1, and 26% were in group 2. And as you can tell by the demographics in this demographic table, the majority of our population identified as male, identified as non-Hispanic, white, and were in the birthday cohort of non-baby boomers. So we've noticed that our population of folks living with hepatitis C have gotten younger and younger, and that relates to the syndemic of the opioid epidemic combining with the hepatitis C epidemic as well. So here is a slide that shows our results. One moment, please. The timeframes between specific parts of the HCV care cascade we looked at were between confirmatory test that determines chronic hepatitis C infection and initial Hep C appointment. And then we also looked at the time between initial Hep C appointment to treatment initiation. So we looked at the time frame between those things, and we looked at them and compared them between groups 1 and groups 2, group 1 and group 2, and between the year 2017 and 2018. And we found that among group 1, folks tested in the community and navigated to the clinic for treatment. Between 2017 and 2018, there was a significant decrease in time between confirmatory test and initial Hep C appointment. And we found that there was a significant decrease in time between initial Hep C appointment and treatment initiation. So both significant among people tested in the community and navigated to the clinic for treatment. We found that among group 2, which to remind you were folks tested in the clinic and then navigated to the same clinic for treatment, between 2017 and 2018, there was a significant decrease in time between initial Hep C appointment and treatment initiation, but the change in time between confirmatory test and initial Hep C appointment was not significant. And I'll talk about that a little bit in our discussion. Our next slide shows the results in approval and treatment initiation rates. Although there was an increase in time between treatment approval and treatment initiation from 2017 to 2018 among both groups 1 and group 2, the difference between the 2 years was only significant among patients in group 1, which means that there was only a significant increase in approval and treatment initiation rates among people who tested positive for Hep C in the community and were navigated to the clinic. Despite, so there was a most significant decrease in time to achieving critical milestones towards a Hep C cure among people in group 1, tested initially in the community and navigated to care in the clinic. And we think this is due to, previous to the removal of the restrictions, people already engaged in care were more likely to continue to be engaged in care. But folks who were tested in the community, our actions as a program of engaging people in care, there may have been times where we were unable to get people in care because we knew that we didn't put as much effort into it because we knew that we wouldn't be able to treat them anyway. And we were seeing this across the country as well. We could keep them in primary care, but we knew we were unable to get an approval through their insurance company. That didn't mean we didn't fight for it, but there were a lot lower rates of treatment approval and therefore treatment initiation among people who were not already engaged in the clinic. Despite these decreases in time to achieving critical milestones, Hep C treatment linkage rates among patients navigated from the community continue to be lower than patients tested within the FQHC. These ongoing delays to care suggest that test and treat models should be developed and evaluated. Other states need to follow suit, and we have programs like the National Viral Hepatitis Roundtable and Center for Health Law and Policy Innovations that are currently involved in lawsuits against states or with states against the laws of states to make it lawful that Hep C cure medications are accessible to all regardless of their substance use level of liver sickness and ability to see a liver-specific doctor. As you can see here, this is an overview of the current, of all states together, and shows the current grading system. Down below, you can see this grading system of A, B, C, D, and F. And like the other maps, the lighter the color, the better the grade, and the least restrictions there are for the states. And over here in Pennsylvania, we have an A, but we have Arkansas down here and South Dakota having an F rating, which means that they still have all of the restrictions that I mentioned before at the highest restrictive level. And a lot of these states in here have our C and D rating, and that means that there are still many restrictions in place. And so what we really need to see is a removal of these restrictions, and as more states remove their restrictions, more legal precedents are enacted, and so hopefully that will create a ripple effect across the country. Our goal is to have all of these states progress lighter and lighter towards an A grade, which we have demonstrated provides patients with their human right to quick and accessible Hep C cure, and uses the treatment as prevention model that I mentioned before in order to eliminate hepatitis C fully. That is done, yes, through treatment of hepatitis C and through these legal lawsuits, but it really is done through community and provider mobilization to advocate for the elimination of barriers. And these are some members of my team years ago, before they enacted the removal of restrictions in January 1st, 2018, advocating for the rights and equal health care for all of our patients and patients we haven't even met yet. There's a lot of advocacy that can be done in Philly. HepCap is the Hepatitis C Allies of Philadelphia, and it's a Philly area collective dedicated to improving the continuum of Hep C prevention, care, and support services in Philadelphia. I recommend you all check them out and get involved, and I'm sure they're going to be opening for meetings once the moment we are able to, and it is safe to do so here in Philadelphia. Thank you so much to Philadelphia Fight. I'm very grateful to be part of the viral hepatitis program, working at both Jonathan Lax Treatment Center and John Bell Health Center. And thank you to Gilead Sciences for some funding for a lot of our ability to provide treatment. Here is my contact information. And please, if there are any questions, I'm happy to take them, or comments as well. Thank you so much.
Thank you, Alex. That was a very informative webinar. I know there was a couple of things that stood out to me during your presentation, and one was treatment as prevention. And that's a common kind of concept you hear not only in Hep C treatment, but also in HIV treatment as well. And based on a few of your slides, I believe it was a slide that identified, I believe it was the year 2016 to current, that there has been some progress made within the states, within the US, towards relaxing some of their restrictions, which is a great sign that folks can receive treatment for hepatitis C, and that advocacy is still necessary to make changes for everyone to have access to treatment towards cure. So thank you for that presentation. Treatment as prevention. So there is a question. Alex, you want to take the question?
Sure. The question is, what will happen if the person is cured and then they start drinking again? Can hepatitis C return? So the answer is no. Hepatitis C can only be transmitted through blood. But I do know that once someone is cured of hepatitis C, their fibrosis level does not necessarily decrease, so still needs to be monitored. And I believe a medical provider would advise that person to at least limit their amounts of alcohol use in order to keep the scarring of the liver as low as possible, because alcohol can definitely speed up the scarring of the liver. Just the hepatitis C will not come back from the alcohol use.
Thank you. If anyone have any questions, please feel free to type in your questions in the Q&A box so that Alex can answer them accordingly. But I do have a question for you, Alex. Just as you were speaking about treatment, what does that look like? What does treatment look like? How long is treatment before someone reaches the cure status?
So sorry, I might have sped through that before. So treatment can be it can be 8 weeks or it can be 12 weeks. And if there is a treatment for 8 weeks, it's typically 3 pills a day. And if it's for 12 weeks, it's typically 1 pill a day. And this will vary based on a person's individual state, and it will vary based on what the provider believes, based on all the things I mentioned before, including the blood work and the treatment history. So a lot of things go into that determination, but these days cure can happen in an 8-week treatment course or a 12-week treatment course. And you better believe we treat people again and again if they get retreated or if they get reinfected. We take a harm reduction approach to this.
Great, thank you for answering that. Any questions, attendees? Anyone have any thoughts or comments for Alex? Yeah, this was a great presentation. I'm really glad to know that Philadelphia Fight is leading the way in this to make sure everybody get treated, because it's really important, especially if there's a cure for it. And so why not get into treatment to address a treatable disease? And so
completely curable. We should be curing everyone.
Mm-hmm. Absolutely. So it looks like there aren't any other questions. And so do you have any last words, Alex?
No, thank you everyone for coming. And this is my contact information. Please give me a call or send me an email if you want to discuss anything further.
Okay, so attendees, thank you again for attending today's presentation. When you hang on tight, because as we end this webinar, you will be prompted to complete an evaluation. So please fill your evaluation to give us your feedback on today's presentation. Have a great day, everyone. Thank you again for attending.